Please let me know once we are live.
Yes, sir, you can start now.
Good evening, everyone. We welcome you all to Ortho TV in association with Zydus. This is the virtual Ortho Academia 2021. To introduce today's topic and speaker, I hand over Dr. Salim Patel.
Thank you, Dr. Neeraj, and good evening to all our respected doctors. We are in for the fourth edition for this virtual Ortho Academia 2021. Today, we have the arthroplasty second phase session and the trauma first phase session. So another interesting line of cases are lined up for today. So let's get straight away with the proceedings for the day. Before we start the proceedings, I would like to introduce our faculty for the day. First of all, our moderator for the arthroplasty session, Dr. Daria Singh. He's a senior arthroplasty surgeon at the Zydus Group of Hospitals from Ahmedabad. He's done his fellowship in arthroplasty at Germany as well as in USA, and his specialty is in revision arthroplasty. As far as the speakers are concerned, our first speaker is Dr. Ashish Singh, the medical director at the Anup Institute of Orthopedics and Rehabilitation at Patna. He's pioneered in the East India to start the robotic Mako surgery for total hip and knee replacements. Has been a member of the Stryker, Marva, and the USA Research and Development team. Welcome, Dr. Ashish, to the platform. Our second speaker in the arthroplasty session is Dr. Nitin Thakkar. He's again a senior joint replacement surgeon with over 20 years of experience. He's been the medical director of the Getwell Orthopedic Hospital, has done his fellowships in revisions TKR and THR at the Helios Endoclinic Hamburg in Germany. Welcome, Dr. Nitin, to the platform. With this, I would now request Dr. Ashish Singh to share his screen and start with the first case proceeding, and that's about Protrusio acetabuli. Over to you, Ashish.
Yes, sir. 2 seconds. So, is my presentation visible?
Yeah, it's just coming up. Yes, yes, you can start, Ashish. It's visible.
Just 2 seconds. Start sharing again because it's not moving ahead.
Sure, sure.
Yes. So thank you, Dr. Salim Patel, sir, and team Zydus for inviting me. I'm going to show you some cases on Protrusio acetabuli. Now, it is worthwhile mentioning that arthrodesis has been the historical treatment option for an Protrusio acetabuli. It is fairly a common condition which I see in my part of India, and the main principles remains to reconstruct the hip center restored back to anatomic position. And there has been different techniques from impaction grafting to mesh or reinforcement using metal cages and bone grafting as well. So we should be aware of the causes of Protrusio acetabuli, and right from post-traumatic Protrusio acetabuli to other fractures which are enumerated in the slide. So let's discuss some cases. Now the first case I will be focusing on a 55 gentleman, which was, he had an injury, road traffic accident. He basically sustained a both column fracture, basically posterior column fracture and part of anterior column, and conservatively managed with traction therapy elsewhere. Now, if you focus on this X-ray, seeing this X-ray, we do have a quadrilateral plate fracture along with the one of the column fractures, which can be better judged on a CT scan. And we go back to the X-rays, and it was presented late after about 6 to 8 months. And the patient had primarily painful fixed hip, and he was neurovascular intact, surprisingly. Now, coming to these sections, you can see the walls are fractured. The column is also distracted. Now, the problems which we face in these cases are relatively young boy, column fracture and quadrilateral plate fracture. And neglected acetabular fracture with Protrusio acetabuli is quite commonly what I feel. So, in these types of cases, what my take is that we have to have a good exposure. No matter you do anterolateral approach or posterior approach, the main thing is that you should have a good 360-degree exposure. And you have to see how much medial migration is there, or the wall is there, or the thin layer of the brim is there. Now, once you have this, ideally you should take X-rays and radiography control in the theater and try to get back your cup to the normal position. And in this case, we did impaction grafting, why I'm showing this, because we managed to do it with a simple cup without anything, because the posterior column had united and the rim was intact. So using a revision cup and impaction grafting, and I would like to highlight that I do impaction grafting with a special technique, and this was couple of months, 2 years follow-up. You see that the medial brim has well settled and the patient is doing very fine. No issues with limb length. The restoration of the hip center was done. So the point here is that in cases where you have the column fractures and medial wall fracture, the columns are generally healed with non-fibrous union, or they unite. If it is fibrous union, we reinforce it with a plate, posterior column, and take it from there. And you can see the serial X-rays which we do. Now, sometimes it is to be understood that you have other options. If the medial mesh rim is not intact, you can use a Murphy's hat, which exactly Chandler sir had it, and I also have it, brought it from Wrightington, and I use it. Or a mesh are of two types. This is a striker mesh, which can be put on the medial wall, and you can on the right hand side see how well it gets settled and contained. You have this debut thin mesh, which is also good. In Protrusio, you can put this, and then sometimes people also put some screws, but sometimes you have to have a combination, which I did, was a cage and a mesh. So these are the cases where you have traumatic impaction medial wall. And important aspect is that you should have a proper impaction grafting set. It is a costly instrument, but you can get it made commercially, and these are various impactors of all the sizes. So I do it with graft slices and impaction graft slices and this graft, the chip graft. So I use a combination, and this is not usually described, and I present it like a sandwich. Like I put some medial, if I require a mesh, I put a mesh, then I put some slice, then I put a mesh. And in the last case, I didn't need to put any metal work in the medial wall. And sequentially, I then impact it with the appropriate impactor. And I have published this in one of the journals and named it after Singh's sandwich technique. So this is one aspect where the trauma you have, and you have medial wall QP plate fracture, and you take it from there. But importantly, you have other cases, especially in rheumatoid. I have a lady who was bilateral protrusio and almost bedridden due to pain, and she had fixed external rotation, internal rotation, and she was having FFD in the knee as well. Now coming to the serial X-rays and the CT scan, you can see that it was having a protrusio with medial migration, and this is the way we try to fix it up. And unfortunately, the things which I'll discuss in my next couple of slides, the problems which we face. You see on the right side, I put a long stem. The reason was that we had a stem fracture. In Protrusio acetabular, two things we have to be very clear. There is aberrant sciatic nerve. Secondly, dislocation is difficult and there is no movements present. So in situ dislocation, especially in this case, where it was not possible to move the head at the femur at all. So we did an in situ osteotomy, and then the graft was taken out, rimmed under image intensifier control, and then we tried to get back the center whatever possible. And then it is very important to make sure that you adequately impact the cup. So whatever we do in Protrusio, the take home message by seeing these cases is that in trauma cases, you have to know the acetabular defect, classify it accordingly. And actually Judet and JNL classification is only for trauma. And then on opening it, then we classify it according to AOS and take it from there. If you have head, then autologous bone grafting, there are n number of methods of impaction grafting. The reconstruction relies on the ability to gain biological fixation. So you should make sure you have a good cup, the revision cups basically, and it should be augmented with multiple screws. Dislocation is difficult. You have to be ready for in situ osteotomy, and sciatic nerve is aberrant in 14% of the cases. So reconstruction of the hip is an attractive option, but a backup plan should be ready with the cage. And I have just submitted a case of 51 impact in Protrusio cases in one of the journals, hoping to get it published. And we have just used our string sandwich technique with 5-year follow-up. So I would be happy for any questions.
Wonderful, Dr. Singh. You have both the cases, both are very good cases. And there's evoke a lot of, I hope, a lot of questions must be there related to these two cases. I have two observations, specifically one for dislocation. As you said, dislocation is difficult in Protrusio and you have to take care of sciatic nerve palsy.
Yes.
So for dislocation, if you are able to, you have a good movement and this just posterior inferior part of acetabuli is blocking the dislocation, then you slightly chisel out that part of the acetabulum and then you can dislocate. Another is if you are not able to dislocate, then you should be ready to do in situ neck osteotomy. The second part which I want to emphasize is that the orientation of the cup should be slightly horizontal if you compare with other pathologies. To transfer the weight on the supramedial aspect rather than medial wall. These are my two observations. Otherwise, fantastic presentation, great cases, wonderful.
So one thing which is very important in Protrusio, which I would like to highlight to all the members who are sitting here and my people, doctors, that the head, the femur is fixed in external rotation or sometime internal rotation. So in situ osteotomy should be taken a bit more, and then when you have cut it, then you can do the neck cut appropriately and take it from there. Since I am working on the Mako platform now, so now we plan it on the Mako and adjust our cup center there, and then we rim till there and then impact with the proper instruments. And these instruments are very costly from the companies, but custom made can be done. I have contacts in Bombay and Delhi. They make it. Couple of ₹1,000 and it's worthwhile to have it, sir.
Great.
And I published my paper and 50 it's going to come up in one of the good journals soon. 5 years outcome, sir.
Congratulations.
Thank you, sir.
Dr. Salim, do we have any questions from audience?
Yeah, sorry, I was on mute. I'm sorry. There is one question, Ashish, regarding your experience about APC cages and how frequently have you used them in your cases in which you have done of late?
Yes, sir. My experience with the cages is I have my cages in the half ring backup, in the backup always. It is on shelf, but I don't use because putting and placing the cage is very important. And then you don't have the cup cage construct in India. So then you have to go for cemented options. So somehow I am not very, I somehow in acetabular fracture, I have again sent for publication a paper which is the reconstruction of the posterior wall, plating it, the fibrous union, and not using a good a cage, but trying to preserve the bone. So my experience is not much, only 5 cases till now where I have to put a cage, and one I showed here. And one case now my cage has broken. I mean the one part has broken because it is a very sturdy construct actually.
Dr. Ashish, can I ask you a question?
Yes, sir.
Yeah. So if you use a trabecular cup,
Yes, sir.
do you think that that is one of those things that is helping us to avoid putting a cage of thing, because the fit that you get with the trabecular metal with a circumferential fit,
Yes, sir.
that can so many times unload the area where you don't want to. So using more of trabecular metal will sort of help it.
Yes, sir. Usually I have more to bias towards gription and
anything that is going to give you a primary stability.
Yes, sir.
The peripheral fit.
Yes, sir. I try to use a PSL cup in striker, get a peripheral stability, and while rimming also, we have to be very cautious so that we don't break the outer rim and the cup gets more focused, fixed there, and medial wall is impacted in pressure. I mean, it's very well packed. So good outcome is there actually with proper impaction grafting. But one thing should be known, that we should not do reverse slimming, because the size of the chip should be 8 to 10 millimeter cube. Number one. Number two is that we should have large and small grafts, not very small, because it is not resistance to its own torsional forces. There is one paper, engineering paper. So I use mixture of big and small grafts, impact it in a good way under pressure with trabecular metal peripheral cup, and try to put screws and take it from there, sir.
Good guess.
Right. Thanks, Ashish.
Welcome, sir.
Yes, Ashish, thank you. And you can just unshare your screen.
Yes, sir. I'll do the stop share right away, sir.
Yeah, right. So I would now request Dr. Nitin Thakkar to please share his screen. And he's going to talk about a case on medial defects in primary TK. Over to you, sir.
Thank you, Team Zydus, for inviting me in orthoacademicia 2021. Today, I'm going to speak about the medial defect in primary TKR. So we know bone defects are very common in India due to very late presentation for surgery. Patient walking with severe lateral thrust gait, showing large lateral opening on X-ray, have a more medial bone loss. These are the causes for bone defects in primary TKR. First and foremost is the severe arthritic angular deformities, in which the varus deformity is most common, which causes posteromedial tibial defect, and that is mostly uncontained type. Second one is the valgus deformity that causes symmetrical defect on femur and tibia on the lateral side, and that is mostly contained type. Post-traumatic arthritis and post-HTO patient also has bone defects. Even inflammatory arthritis like rheumatoid arthritis patient also have severe bone defects. Hypoplasia and osteonecrosis are the other causes. From the types of these are the types of the defects based on the location, either it is central or peripheral. As I said, varus knee can cause posteromedial peripheral defect, whereas valgus knee cause lateral central defect. Based on the margin, either they are contained or uncontained. Contained are also called cavitary defects, uncontained are also called segmental defects. Rand has given classification of bone defects according to the percentage of the single condylar involvement and according to the depth of the defect. Management options for any bone defects are either lateral translation of the tibial component, lower tibial resection, cement filling with or without screws, autologous bone graft, impaction bone grafting, allograft, metal wedges or augments, sleeves and cones, and semi-constrained or hinge implants. So this is my case, which was presented or published in the Asian Journal of Arthroplasty. Autograft is a biological and economical alternative to metal augments, wedges for severe medial tibial condyle bone defect in primary TKR. This is a case history. 58 years old male, chronic smoker with COPD, presented with severe degenerative osteoarthritis of both knee in March 2017 and was advised elective total knee replacement surgery. These are his X-rays. But due to financial constraint, patient neglected his disease and developed intra-articular stress fracture of medial tibial plateau along with severe bone loss. Patient was having some minor trivial trauma that was in the history. In right knee, after a span of around 1.5 years of the advice, there was a resultant severe pain and difficulty in standing and walking. Right-sided TKR surgery was planned for the patient. One can see on the X-ray, there is a intra-articular stress fracture on the medial tibial plateau. This is his pre-operative gait. He was unable to put a weight on the right side because of that intra-articular stress fracture. Intraoperatively, a 30 mm deep uncontained defect of the medial tibial plateau was found due to non-united fracture in the arthritic medial tibial plateau without any extra laxity of MCL ligament. In order to reduce the extra cost of the metal wedges and augments, autograft from the distal femoral cut fixed with the 4 mm CC screws was used to tackle the uncontained defect along with the uncemented tibial stem of 16 into 115 length to bypass the initial load over bone graft surface, thereby facilitating adequate union. Pre-planned and meticulously executed conservative bone cuts and soft tissue dissection during the surgery led to the successful achievement of the ligament stability with tibial insert of only 8 size of PS variety, avoiding use of the expensive constraint implant. These are the pair of pictures showing the defect. These are the pictures showing the fixation. The defect was around 30 in a size, and 1/3 of the medial tibial condyle was involved, which was fixed with the 4 CC screw, and final implantation was done. This technique is developed by the Skulco, where we just initially cut the defect, and sometimes we use the burr to remove the sclerosed part, and then we use the cancellous bone from the distal femur, and we co-opt these two cancellous surfaces and provisionally fix with the K wires, and we recut the tibia for the leveling. Divergent cortical screws are inserted using the leg screw technique away from the tibial keel and cement, and caulking technique was used for the cementation to avoid the penetration of the cement in the these co-opted bone surfaces, and which will prevent the non-union of the bone graft. And then limited weight bearing of the patient is allowed, and serial follow-up X-rays for consolidation of the graft. Sometimes we have to use the tibial stem. For that, the trace the tray technique is used, or this test is useful. The test is if you find tibial tray lift off, when you trace the tray over the defect, it indicates the need for long intramedial stem to relieve the mechanical pressure from the graft and protect the graft. There is another technique which is called step cut technique. Here we prepare the defect in a step cut manner, and we insert the screws in a vertical fashion. This technique is mechanically more sound because of the vertical direction of the screws. These are the post-op X-rays and clinical pictures comparing pre-op and post-op patients' deformity in AP and lateral views. The patient was instructed for partial weight bearing for initial 6 weeks post-operatively, and good consolidation of the autograft, complete correction of the deformities with excellent range of motion from 0 to 130 degree was found at the final follow-up at the 6 month. These are other pictures showing the clinical outcome. These are the pictures showing pre-op and post-op patients standing at OU, and this is the post-op gait. Thank you.
Wonderful case, Dr. Nitin.
Thank you.
Dr. Salim, do you have any question from audience?
Yes, sir. 1 minute. I'm just checking. Yeah. There's one question, Dr. Nitin.
Yes.
It's regarding post-fixation of this medial defect.
Hmm.
How early do you mobilize the patient? Is it immediate, or you wait, you give it a slab, or maybe a support in case the defects are too large? So what is the protocol you follow?
It depends on your fixation of the stem. If you are using any stem for intramedullary in a tibia, along with that, how is your fixation of the autograft? Generally, I take care that initial 6 weeks I allow them partial weight bearing, and then if the graft is uniting, I allow them full weight bearing. I do not give any slab for this kind of thing. I immediately start good range of motion to prevent any stiffness in the knee.
Right, right.
I agree with.
Yeah, I have a small question.
Yes.
Do you, as a routine, use the stem extenders, or you don't want to use the stem extenders when you have filled such a large defect?
No, sir. It is as I said. I perform this trace the tray technique. If after putting this tray on the before fixation of the tibial tray, I put this tray and then I trace over the defect. If the tray is moving, then I use the stem extender because it implies the instability, or it indicates that need of the tibial stem.
Okay. Wouldn't it be a worthwhile thing to extend the stem so that you are giving a decent support? Like you mentioned that there was a stress fracture. So the
Yes.
stress fracture, the modality is that you go to diameter length below the fracture area.
So this was not a stress fracture in the tibial diaphysis or metaphysis. It was a fracture of the medial tibial condyle. Intra-articular varieties of stress fracture. That is the thing you are talking is a different one, where we have to bypass the this stress fracture to diameter of the tibia. That is a different variety.
But as a rule, you start them walking on day one.
Yes,
Depending
partial
on
weight,
the situation.
yes, depending on the fixation, partial weight bearing is allowed.
Have you used allografts for that?
No, sir, I haven't used
No,
allograft.
not used allografts. Now, is there any comparison between the autograft and the wedges? Like, have you conducted, or do you have any references wherein the difference in the results were there?
So both has
Long-term results I'm talking about.
I'm not much fan of the metal wedges, but both has a pros and cons. When you are using augments and wedges, your surgery is very simple. But in that you have to lose more bone because you have to do the step cut. And here we recreate the replenish the bone. So in future revision surgery, autograft will be more beneficial. So whenever the patient is having young one, I try to use autograft to replenish the bone of the tibia.
Any ligament attenuations over the bone graft or over the screw area?
No, sir, I
Have you
haven't
noticed
found.
them?
No, I fix the screws very
You
meticulously.
flush it.
Otherwise, yes, it can happen if you protrude your screw head much, then probably it can. Even with the wedges, this problem can occur. So that is the issue with the wedges also, because the wedges are much protruding towards the medial surface, and that can irritate the MCL ligament.
Okay.
Right. Yeah, Dr. Ashish, any questions from your end?
Thank you.
Very well done, sir.
Dr.
Very
Zaki,
well.
sir, anything from your end?
2-3 observations. Number one, you should cut minimal tibia in these kind of cases, which Dr. Nitin Thakkar has rightly did and said. Second is stem extensor, as Rajesh Gandhi sir was asking. Stem extender is a must, which Dr. Nitin Thakkar did. And you can do immediate weight bearing. There is usually no issues. But if you are worried about stability of the stem or stability of the fixation, you can wait for some time to start healing taking place. So that's all. And wonderful case, Dr. Nitin.
Thank you. Here the patient was in a chronic smoker, so I was little worried.
Yes, very well. Yes, because we don't know even etiology of that kind of bone restriction also. So this may be avascular necrosis of the.
Sometimes intra-articular steroid also can cause this kind of thing.
Steroid can also cause. You did right thing. There is no issues.
Yes, sir.
Right. So we'll go ahead with the trauma session now. Before I start with the session, I would like to introduce our moderator for this session. It's none other than respected Dr. Rajesh Gandhi sir. Dr. Rajesh Gandhi sir is a medical director of the Gandhi Nursing Home, a senior consultant orthopedic surgeon at Hinduja Khar and Ramakrishna Mission Hospital. Sir has a practice of over 30 years in orthopedics, is currently now the president-elect for the Bombay Orthopedic Society, and also has been a pioneer member of the JES Research Foundation. Welcome, Dr. Rajesh Gandhi sir, to the forum.
Thank you.
To start the first case in the trauma session, I would like to introduce our first speaker, respected Dr. Dilip Shah sir. Sir is an honorary orthopedic surgeon at the Saifi Hospital, Nanavati Hospital, the St. Elizabeth and Kambala Hill Hospital, ex from the department from the Nair Hospital, and also a panelist consultant at the ONGC Mumbai. Sir is an AO course faculty since 1985. He's won multiple fellowships at the CCOT, AO, and at the BOS fellowships. He has numerous publications in both national and international journals. He's the editor-in-chief of the ASOR Honorable Editorial Board for the 4th Journal of Orthopedics and Sports Medicine, a national coordinator from India for the AOS Saturday conferences from Chicago, and has done the maximum number of webinars of late in this COVID lockdown. I welcome Dr. Dilip Shah, sir, and I would request him to share his screen to start the proceedings. Over to you, sir.
Thank you very much, Samir Patel, sir. I am really so thankful for you for allowing me to speak for orthoacademicia. And my topic today is IT fractures of femur. It's an unsolved enigma, and I would like to explain and try to get out some solutions, not by one case, but multiple cases, as I've been suggested by Dr. Salim Patel. This is the first case, non-union implant failure in 88 years old female. There is 2 years of non-union. This is probably during the first fixation, and on day 1 failure, what we call, it looks like that. And this is how it progressed. And this went on as non-union. Patient was bedridden. And at the end of 2 years, when I inherited the patient, this is the situation. So what will you do in this situation? This is a burning question, and IT fractures almost 30% of failures. What next? So the solution to this is a solution hip. But then let's see that if we can, as always we have been saying, prevention is better than cure. So another example, 23 years old patient with road traffic accident. There is a shaft femur fracture as well as basal IT kind of fracture compound. So what would you do? Here you can see the basal fracture, which is almost going up to the IT level also. So what will be the situation? What will you do in this? Debridement, then second stage surgery. And this is how with one implant, like you can kill 2 birds with 1 stone, you can have a good fixation. So you should have knowledge that what implant is going to be best suited for this situation. And this at the end of 2 years, the healing, which is so good. Now, how many of you do Diamond Houston medialization? Or actually, Diamond Houston, they themselves have stopped doing it, but in Indian circumstances, where you have severe comminution and likelihood of collapse, medialize, because otherwise the cortex at the point of entry will fracture and it will get medialized automatically. So you will end up by putting too long a screw. So this is how you will do it. You enter from the fracture site, make the neck shaft angle almost 160 to 170 degrees. This will increase the stability. At the same time, it will compensate for the shortening which you are going to cause. This is a fracture. Enter from the fracture site, aim it either centrally or inferiorly. Telescope the beak into the shaft, make an angle of 160 to 170 degrees, and you can see wonderful result at the end of 3 months. So this is how you can prevent the failures which are going to happen. Now, I want to emphasize reduction is the key point in all fractures. Look at this. Can somebody think about what will be the best position in which you can do reduction? Tried various reduction possibility. Now, there is something unusual. And there are some fractures which reduce only in external rotation. So remember this point. Otherwise, you will unnecessarily open and do open reduction internal fixation. And this is such a wonderful result. And this is after removal of the material for synthesis. Now, there are some bones which are so thin that when you enter from the lateral wall, you have a feeling it is going to crack over there. For that, I have devised pediatric Richards. And this is how you will use a pediatric Richard, and you will get even extra space to put one anti-rotation screw. You need trochanteric stabilization plate when you are trying to use unstable fractures with the DHS. So this is how you can use TSPs. Look at this example. So the TSP will be adding only if you are going to use DHS. I'll come to a point later on, which by my example, I'll show you how you can manage such kind of fractures, which are very unstable. Now, if you have lesser trochanter also, which is of big type, then look at this. Lesser trochanter can be so small or it can be huge also. So if you are using a DHS, then you need to stabilize the posteromedial fragment. These are some of the examples. Now, there is a case, 85 years old lady with severely porotic bones, a good fixation with anti-rotation screw. It was healing well, but she had a trivial fall and she got a subcapital fracture. Now, what do? You can do either a total hip or a bipolar. So this gives me an idea that if we can use bipolar as a secondary procedure, why not do as primary in very porotic bones? So these are some examples where I've used primary hemiarthroplasty also for intertrochanteric fractures. So hemiarthroplasty established in cases of subcapital or transcervical fractures, but not still. And there are some people who feel it's controversial. I would suggest whenever you have a problem, there are increasing chances that you can do a total hip arthroplasty or bipolar, which I have been doing routinely. So it's very clear that for stable fractures, you can use compression hip screw. Unstable fractures, A3 type, you can use nail. There is only a thin boundary for A2 types of fracture, where they being unstable, you need to use proximal femoral nail. There is another example of 73 years old lady with T-score minus 4.5. And look at this fixation. It works wonderfully well. So my take-home message by all these examples which I gave you, choose the implant with which you are comfortable and well experienced. Reduction is the key step in successful outcome. TSP should make the construct stable. That is when you're going to use a DHS. Posteromedial fragment also can be stabilized by a cerclage or etc. Diamond-Houston medialization sometimes is necessary evil in highly unstable fractures with lateral wall fracture. Pediatric Richard when a lateral wall is very small. Additional anti-rotation screw to impart more stability in highly unstable fractures 3-1 A3 types. PFN is ideal choice, and do not stretch your indications for doing DHS too much. I thank you for your patient and wonderful listening to me. Now, if there are any questions, I'm really very happy and I'll be really glad to answer all your questions.
Very crisp and super presentation, as usual. Just a couple of points I wanted to clear. One thing is that in which particular case you would prefer coxofemoral bypass over the traditional fixation method?
Wonderful question, as usual, from Rajesh Gandhi, which may be a common question for everyone, especially on people. Anesthesia point of view, they are of very bad grade and you don't want to have another surgery. Very porotic bones, moribund kind of patients where you want to make them stand on the next day and you don't want to have any embolism or any other complication, then a bipolar should work very well. Why bipolar? Because these people had normal movements earlier. If you do total hip, they are likely to dislocate. But if you are very good at doing total hips also, you can go ahead. But as you said, coxofemoral bypass is for moribund patients. You don't want to give second anesthesia, severely porotic bones, and very unstable fractures.
And do you always fix the trochanter or once in a while you leave them free?
In coxofemoral bypass or in general?
Yes.
In coxofemoral bypass, yes, you try to align it. Now, I want to give you my trick. I use number 1 vicryl double equal, because if you put wires over there, wires after sometimes may show breakage and it may cause a medico-legal complication, or your fellow colleague only will say, oh, what stupid fixation. So it is temporarily to have assessment. And if you see the results, those who have been fixed for greater trochanter especially, they are stable for initial 3 weeks, but after 3 weeks, all of them are same. Because these are very moribund patients and they are very old people. So the abductor function, you just bring it to the best possible. But you don't want to make it absolutely strong like you would do in a total hip replacement in a young patient.
Yes. And about the nailing part, how often you have had to use the trochanteric plate? Additional fixation. Now, a lot of talk is going on about the lateral wall fixation, lateral wall stabilization, and all of us have faced some problem once in a while. Now,
Look, do not
to
consider
avoid
me
that?
to be, yeah. I am not paid by Smith and Nephew. But my feeling is
I love
if you
that.
learn the art of intertan, even if you don't have a strong lateral wall, if you don't have a medial, posteromedial, I can show you ample of examples where it is successfully really carried out well. So that doesn't mean that I insist you use intertan, but I have been very successful with intertan. Lateral wall, exaggerated fixation, it is like overkill.
Now, in that, when you are using interten for the sort of a comminuted lateral wall, you would use a longer nail or you will use the normal standard 180 millimeter nail?
Depends actually, because if you try to use longer nails, sometimes they have a lot of bowing of the femur also. So you have to take into account that. So if the fracture is going to subtrochanteric level, then you have to use a longer nail. And then diameter of the nail is also a very important point. And then if you feel that you need to really put a thicker nail, you may do femoral nailing like you're doing a femur nail.
Now, here I want to
Reaming,
ask one. Yeah.
femoral reaming.
And that's what I wanted to ask you. Now, do you, as a normal procedure, would you do a reaming in all the cases or you would do in a selective individual?
In selected cases, sir, because generally I start with 10 number size nail, okay?
Okay.
But if you feel that the fracture has gone down a little bit subtrochanteric level and you want to put a longer nail, then you don't want to end up with a impacted nail, which is another disaster. So you ream with whatever size you are going to put 1.5 millimeters extra.
Thank you.
Thank you. They were wonderful questions, really. Thanks a lot.
Thank
and
you
I
very
thank
much.
Salim Patel, sir. You were really so nice to me. I will discontinue using my screen share so that other people can have advantage now. Thank you.
So there's one question from the audience for you, Dr. Shah.
Yes, sir.
For the new generation, would you recommend them to first learn on the DHS and then think about the newer nails? Because nowadays, if you see, the newer generation is more keen towards PFN and TFN. So your message to them, sir.
For stable fractures, grade A1 type, use DHS because you have a machine gun and you have a rib pistol. Okay, you don't use machine gun for smaller things, like it's that way. So unless you put DHS well, and besides when you're going to use a PFN, it's a bigger challenge, although it's a small one, but then it is unnecessary, as I always use the terminology overkill.
Right. Perfect, sir. That was a crisp message. Thank you, sir. Thank you.
Thank you very much.
So now I would request our next speaker. First, I would just introduce him. It's none other than Dr. Anil Kumar V. Dr. Anil Kumar V is a senior consultant orthopedic surgeon from the Semakalm Hospital, Ottalam in Kerala. He's designed his own K-wire jig for pinning for distal radius fractures, has successful presentations at various international forums in Singapore, USA, and South Africa. And today, sir is with us to talk about a very interesting topic about supracondylar humerus fractures in pediatrics with his close reduction and percutaneous pinning. Over to you, sir.
Thank you.
So you need to press the green screen button, sir. Share screen.
Oh,
So the share screen button, if you can just click on that and you can open your presentation then, sir, from the desktop. Yeah. Yes, sir. Now you can just click on your presentation. So you can just minimize this window. Then on your desktop, you can click on your presentation.
Oh, it is not coming, sir. Just for a minute.
Yeah, yeah. Yes.
Yes, sir. Good evening, you all, sir. Sorry for the inconvenience.
No issues.
I am Dr. Anil Kumar from Kerala, presenting an innovative method of CRPP for type 3 and 4 supracondylar fractures of the humerus in children. Supracondylar fracture of the humerus is one of the most common injuries in pediatrics, and accounting of 16% of all pediatric fractures and 60% of all pediatric elbow fractures. I'm not going to the details of the classifications, and also regarding the treatment modalities also I am not going. I am presenting the type 3 and 4 fractures by my own technique of CRPP. This is the demography. CRPP done in 40 cases of type 3 and 4 during 2017 to 2020. Age group is 1.5 to 16 years. The first step of this CRPP is a close reduction, which is done in 3 steps, and the distraction of the fracture fragment done by traction countertraction technique with an assistant in the line of the humerus in a slightly flexed position of the elbow to disengage the proximal fragment from the muscle and thereby protecting the iatrogenic neurovascular injuries. This can avoid the complications of the conventional joystick method of close reduction through the medial epicondyle and also the milking maneuver. The compression of the fracture may be required in intercondylar extension type of fractures. After primary clinical judgment of the reduction is done, and the clinical judgment was done by the orientation of the imaginary triangle created by the olecranon with respect to the epicondyles. Imaging was not done at this stage because it may lead to the loss of reduction. You can see this video for the rotation corrections. The fine correction can be done at this stage with the distracted position itself. That's the main advantage of this. And we can proceed for the spinning technique. First step of the percutaneous spinning was done with the 2 caveats of 1.6 mm in crossed manner from the medial epicondyle and second from the lateral epicondyle, sparing the olecranon fossa without any skin incision. If the fracture has a bicondylar extension, it should be fixed first with a transverse cavea from the medial epicondyle below the olecranon fossa by maintaining the compression of the distal fragments with the hand. We can see the picture of the orientation of the wires from the figure. The percutaneous spinning of the second set for confirmation of the cavea, the position, the imaging was done with ZIA and the projecting end of the cavea shortened for smooth introduction of the second set of wires. The third wire from the lateral epicondyle and also the fourth wire from the medial epicondyle. The final confirmation of the cavea position were checked. After confirmation of the position, the cavea is shortened and placed into the subcutaneous plane. The end of the cavea is bent and placed in the subcutaneous plane with the cavea bender and also wire cutter. We can see the bending of the caveas and cutting short by giving deep pressure towards the bone. This is the end of the wire is placed into the subcutaneous plane by pulling with the thumb forceps. There was so that there is nothing will be seen outside, and a POP slab is applied in 90 degrees of flexion. Regarding the postoperative protocol, patient is discharged on the second day and reviewed after 1 week for check X-ray, and third week the plaster is removed and check X-ray is taken, and active elbow exercises by the patient for 1 more week, and caver is removed at 4 weeks, and review after 6 weeks, 12 weeks, and thereafter 6 months for 3 years. These are the sample cases, the variety of cases of type 3 and 4. That is, these are the 11 or 12 different cases which I have done during the 2017 to 2020. This is a 10-year-old boy with a severely comminuted supracondylar intercondylar fracture with an extension to the diaphysis, and which has taken the video at 6 months and X-rays of both upper limb for comparison of the results of the cosmetic as well as functional results can be assessed from here. This is an 11-year-old boy with a supracondylar fracture of the left elbow, 3 years after taken the video, and also the elbow X-rays of both upper limbs. You can see the preoperative X-ray and postoperative X-ray also there. This is an 8-year-old boy with a supracondylar fracture of the left elbow at 4 years. You can see the cosmetic as well as functional results from the video as well as from the X-rays of both upper limbs. This is an 11-year-old boy with a supracondylar fracture of the right elbow at 1 year. You can see this preoperative X-ray, postoperative X-ray, and also X-rays taken at 1 year of both elbows for comparison. This is an 8-year-old girl with a supracondylar fracture of the left elbow at 1 year. You can see the preoperative X-ray, postoperative X-ray, and the X-ray taken of both elbows at 1 year. From the video and X-rays, you can assess the clinical, cosmetic, and functional results. This is a 12-year-old boy with a supracondylar fracture, left elbow, the 3 years after the taken the video, and the preoperative X-ray, postoperative X-ray, as well as the X-rays of both elbows are shown for result comparison. This is a 7-year-old boy with a supracondylar fracture, right elbow, the video and X-rays taken after 9 months, and preoperative X-ray and postoperative X-ray and figures are also shown there. And this is a 6-year-old girl with a supracondylar fracture of the right elbow, 9 months after the injury. You can see the preoperative X-ray, postoperative X-ray, and also the X-ray taken at 9 months for the evaluating the cosmetic as well as functional results. This is a 5-year-old girl with a technically compound supracondylar fracture elbow, 4 years after taken, and this was the one case in which the varus deformity was evolved. That is because of that compound nature. I was afraid of doing the deep close reduction in a superficial manner. That's why it was happened, but the full range of motion was achieved. You can see this range of motion as well as the X-rays. This is a 7-year-old girl with a flexion type of supracondylar fracture of the right elbow. And you can see the pre-op X-ray and post-op X-ray here. I have used only 2 cavities because the fracture is very close to the epiphysis and there is no space for the introduction of the second set of wires. And so, because of its crossed nature of the spinning, it was very well worked and the good result was obtained and full range of motion was achieved in 3 months. This was an 11-year-old boy with a supracondylar fracture elbow at 1 year. Here, I have used only 3 cavities because there was a bad skin in the medial side for the introduction of the second wire from the medial epicondyle. The very good result was obtained. These are the results of the 40 cases. 38 cases have excellent cosmetic outcome and 1 had good result and 1 has fair result. excellent functional factors in all cases at 6 months, and radiological measurements of the carrying angle and angle of movement between the injured limb and normal limb were showed equal or 0 to 5 degrees in 38 cases, and 5 to 10 degrees change in one case and 11 degree in one case. And Mayo elbow performance score is also maximum score achieved at 6 months. These are my complications. One case had a varus deviation of 11 degrees. 2 cases had a superficial skin infection subsided with antibiotic therapy, and pin loosening happened in 1 or 2 cavities. But because of the 4 number of cavities, which was not affected in the stability of the fixations. No major complications like neurological, vascular, or adverse stiffness. No compartmental syndrome were encountered pre or post-operatively. No patients required reoperations. Regarding the discussions, the timing of the treatment, and also the positioning of the cavities, there are controversy in the literature. We can discuss it here. These are the results. In conclusion, the modified method of CRPP can be successfully applied in the treatment of type 3 and type 4 supracondylar fractures of the humerus in children for getting a superior result, avoiding the usual complications. Thank you. Thank you, sir.
Thank you, sir. Yeah, Dr. Gandhi, any questions from your end?
Yes, sir. Dr. Saab, very good presentation, very informative and very encouraging also. Now, one thing which I have always been surprised is how many times you are worried about the spike piercing through the anterior muscle mass and possibly hurting the brachial plexus, brachial artery. How
Yes, sir.
commonly you encountered that?
Sir, previously I was doing with this milking technique and also this joystick maneuvers, but this technique of distraction, distraction means a very good distraction, that is disengaging the proximal fragment from the muscle mass by action in a slightly flexion, 20-degree flexion of the elbow I am giving. And also that the distal fragment is holded by one of my hands and it is flexing, and so that because of that muscle, the proximal fragment will be disengaged easily from there, and we can reduce it also. Till the introduction of the wires, I will keep this traction without losing. That is why I am not checking these positions also. Because of it may, if we are going for a checking, there may be a fatigue of the hands of the assistants or my hand, and the end of the reduction may be lost, or the spike may be gone into the this neuromuscular bundle. In my experience, this is the best technique for avoiding these neuromuscular complications, iatrogenic neuromuscular complications by the surgeon.
Good. And another question is that when you are maintaining the traction, you mentioned about it, and you told that from olecranon fossa, next to olecranon fossa, you enter. Now, there are times in a flexed position, it is not easy to isolate the median nerve when you are going from a median side. So you go there or you go at the epicondylar level?
Sir, even if there is edema, that is in the late presentation cases also, we can identify this ulnar nerve because this middle epicondyl, we can palpate it by giving a deep pressure with the thumb for 1 minute. We can displace the edema from that area, and after that we can feel that ulnar nerve, and which can be pushed backwards.
Okay.
And till the completion of the cavities from the middle side, that nerve will be in the hand of in my hand, that is with the thumb or index finger, depending upon the side, left or right.
You use a plain KVS or a threaded KVS?
Plain KVS, sir. Plain KVS.
Okay.
So that we can without imaging, I am doing this thing. So I am feeling this the penetration of the KVS through this cortex, medullary cavity, and the opposite cortex from the resistance which I felt in the drill. That's why I'm using this smooth KVS for this case.
And other thing is that I have seen your lower radius presentation wherein you use a small mini X-fix for keeping the fixation while you are doing the fixation. Do you use any such device or you do freehand?
No, sir. It is only free hands. Only
Freehand.
one assistant will be with me for till the completion of the first set of wires. After
Have you
completion,
tried?
pardon, sir.
Yeah, please go ahead. Sorry, sir.
Because I am putting this wire from the medial side is the first wire. That is because that medial epicondyle we can feel and locate it very correctly. So that from the lateral side it is very difficult for the younger child to this feeling of from the lateral side because that area.
Mhm.
But here the point of entry can be pinpointed from the medial side, and also once we are pushing back the ulnar nerve. We can pinpoint the location, and also after that pinning, that the fracture will be stabilized. There won't be much rotations while fixing this medial side. If you are going for this lateral side first, then we have to rotate it internally. That may rotate. There may be a chance of rotation, internal rotation of the distal fragment before doing that fixation. During that fixation. So I am doing from the medial side is first, and the fracture will be stabilized. Then there won't be any movement at all. And also the maintaining the distraction till the first set of wires are inserted.
How many wires you generally put? The common numbers like 3, 4, 5, or it is as much as required?
Yeah.
Depending
So
on the
generally I am using 4 wires. That is 2 from lateral side and 2 from medial side. Depending upon the local conditions, I may reduce it from the medial side. It is if I cannot put 2 wires, I will restrict it for 1. From the lateral side, it is very easy. We can use you can use 2 wires, and also in one of my cases, it was lower third humerus is also fractured. It's a separate butterfly piece was there. I was fixed with the additional cavities from that side also. That's the first case.
Have you ever faced epiphyseal injuries later on, long term, when
No,
because you're crossing the epiphysis on both the sides with total 4 wires?
Yeah.
So like there are a lot of studies which does mention that you should not pass through the epiphysis.
Sir, that's a thing. Usually, if the fracture is a little bit above, I will spare this epiphysis. So, I will put it as much as possible through the lateral side, through this metaphysis I am putting. And if it is not possible, I will do it. One of the cases I have shown you that's a flexion type of injury. I have put only 2 wires. That is because the fracture is very close to the epiphysis and there is no space for introduction of the second set of wires. So I have restricted for 2 wires in that case that I have shown there.
Now, your take on one thing, say 2, 3, 4 wires from one side, only lateral side, because a lot of people recommend that put multiple wires from one side rather than going on the medial side to safeguard the medial ulnar nerve. What's your opinion on that?
Sir, the literature also, the more supporters are like that. That is, I am against that because that will reduce the results. That's a complication. So that is a rotational complications are more chance when if you are putting either 3 or 4 from the lateral side itself. Otherwise, if you are putting only 2 wires, that is in a crossed manner. That means it will be stable. That is number 1, the stable fixation. Number 2, after 3 weeks, if we need, we can remove it at 2 weeks also. After 2 weeks or 3 weeks, we can remove the plaster slab and with the caviar, which is in the subcutaneous plate, so that there is no hindrance of the movements also. The patient can do the personal active exercise and there won't be any stiffness. And by the end of 3 months, everything will be fine. In 95% of my cases, it's like that, sir.
Very good presentation, sir. Thank you for sharing.
Thank you, sir.
Thank you.
Right. Sir, can you unshare your screen? So I will just share my screen.
Mahendra bhai, namaskar.
Hi, Rajesh bhai. How are you?
Hope to see you very soon in Goa.
Yes, I'm waiting to welcome you and Dilip bhai.
Yes, sir.
Right, sir. So we go on to the last presentation for the evening. It's none other than Dr. Mahendra Kurchadkar, sir. He's a HOD and the Chief Orthopedic Surgeon at the Healthway Group of Hospitals. He's been the ex-president of the Goa Orthopedic Association in 2006 to 9. Sir has been the Vice President of the Indian Foot and Ankle Society in 16 and 17, as well as the ex-president for the IFAS. And today, sir is there to talk about an interesting case presentation about Lisfranc's fracture. I would now request sir to share his screen and start the case presentation.
Yeah, Salim bhai, I think my presentation is not exactly a case based.
Right.
There was some communication, but I will make it as interesting as possible.
Right, sir.
And because in the Lisfranc fracture, we cannot really drive home the points that are required. But anyway, thank you very much for the opportunity. And that's my screen. Okay. So I will go through this presentation very quickly because so that I have to cover a few points about. Now we all know that this injury was described by Lisfranc, but it was described only by an amputation, not exactly the injury. So he got this his name on this injury because the injury went through the Lisfranc joints. Basically, the stability of the Lisfranc joint is decided by the shape of the metatarsals and the way the second metatarsal recesses inside, and it provides the intrinsic stability like the Roman arch. Now, one of the few anatomical facts that you need to know is that the intermetatarsal ligaments, there is no intermetatarsal ligament between the first and second metatarsals. So this is something very important about. Secondly, the plantar ligaments between the cuneiform and the metatarsal is the strongest one, which is the Lisfranc, and the dorsal ligaments are extremely weak. So they've done a study here and they have found that the Lisfranc ligament was the strongest, followed by the plantar ligaments. The dorsal ligaments are the weakest in the structure. And the part of the stability is also provided by the peroneus longus and the tibialis anterior. Now, this incidence is not as less, but the reason is that these are very commonly missed injuries because of the index of suspicion. Approximately 20% of the Lisfranc injuries may be missed and overlooked. Mechanism of injury can be multiple. It can be either a direct trauma or an indirect trauma. But one of the common ways that the fracture occurs is a plantar flexion mechanism where the ankle is in equinus and the metatarsopharyngeal joint also is in plantar flexion, and this causes the rollover type of injury. This is some of the ways where you could, especially while getting down the stairs, commonly in a civilian situation, this is very common. Also, in a road traffic accident, this is sort of the mechanism of injury. Now, classification basically is not really so important in these injuries. It is important to first diagnose them. So just for the sake of completion, I've just mentioned this classification. The Meyerson's classification is the most functional classification because it shows you the classification in terms of the medial, the intermediate and the lateral column in terms of stability. Now in the history and clinical picture, the midfoot, the patient usually presents with the midfoot pain. And most of these patients will have difficulty in weight bearing. And they usually typically walk with a equinus gait. There's a swelling across the dorsum of the foot. And there may be a deformity based whether the deformity is the dislocation is reduced or not reduced. So in a high index of suspicion is extremely important in this patient based on the mechanism of injury, which you have to spend some time asking the patient to do it. In terms of clinical findings, if there is a real compartment syndrome, you have to be able to diagnose it because that can be a problem. You may have fractured blebs depending on the degree of soft tissue injury inside. But one of the signs that is easily missed is this plantar ecchymosis sign. May not come immediately on day one of the injury, but if it is missed, then you please look out for this and you will be able to suspect because this is the tear of the plantar ligament which percolates down into the soft tissues. In a stress test, basically you can do an abduction pronation of the forefoot with the hind foot fixed. This is very typically a way the Lisfranc injury occurs. You can also do the piano key sign by trying to elevate the metatarsal up and down. Now, as I said, diagnosis of a Lisfranc injury is the key. I mean, there is no rocket science in treating this injury. Once you have diagnosed it, the treatment is really straightforward. The problem is that 20% are misdiagnosed and 40% of receive no treatment in the first week. They're all sent home like a midfoot sprain. In fact, 50% of the athletes with midfoot injuries had a normal non-weight-bearing radiograph. Now, the word non-weight-bearing radiograph is extremely important because most of the X-rays that are done with the patient sitting down and just an AP is taken. So how do we confirm this? So in X-rays, you have to take a weight-bearing view or a stress view and compare with the normal side. Because so many times that subtle widening of the gap will be missed. The other things, you can do a CT scan to look for the flex sign, or you can do for the comminution. MRI is something that can be done if the injury is very subtle. Bone scan and ultrasound scans are not so useful. On the AP radiograph, a lateral radiograph and 30-degree oblique view is an absolute must for diagnosing these X-rays, these injuries. If you see a diastasis of about 2.7 mm or a little more, you have to be worried about it. Look for that flex sign because the flex sign is nothing but a bony avulsion of the Lisfranc ligament. Also, one of the things that you can miss is the intercuneiform instability. So when you do open, you have to look for this intercuneiform instability. A lateral view can also show you the step-up sign. And this is a very classical Lisfranc injury taken by a stress view. That's the bony fleck that you see. Now see the difference between a non-weight bearing X-ray and a full weight bearing X-ray. It just brings out the injury which was completely hidden or you could have missed it easily. So taking a stress view is extremely important. And for low velocity injuries, if a normal X-ray is there and you still suspect that something is wrong, you can go ahead and do an MRI. A 3D CT scan can be done in to look out for the occult bony Lisfranc, look for the comminution, for planning of the surgery. And a weight bearing CT is something that is the latest thing and it really helps. Stress fluoroscopy under anesthesia. So how do you manage them? The whole treatment is basically to provide a painless, plantigrade, stable foot. And the key here in Lisfranc is an anatomical alignment. It doesn't matter whether you put in a screw or a plate, but managing this fracture, reducing these injuries anatomically will decide your long-term results. So check the stability. You have to find whether the shift is greater than 2 mm or the gap is greater than 2.7 mm. If it is less, do a non-operative management. You can just put the patient into a cast, short non-weight bearing cast for 6 weeks, a weight bearing cast for additional 4 to 6 weeks, and then you can allow the patient to move around. Now, the biggest question that occurs, and which is a bit of a controversy in Lisfranc injury, whether you want to fix it or whether you want to fuse it. I think the literature really doesn't give you a clear-cut idea. But some of the things that you can take home is that if the injury is a chronic injury, a purely ligamentous injury, then there are better AOFS scores when you fuse them. Lesser chances of recurrences and lesser hardware issues. So it's not that the outcomes are different, but you may have in a screw situation, you have to sometimes remove the screws or remove the implants. So fusing really avoids these issues. Now, in the operative treatment, some of them are surgical emergencies. A thing like this, you can have an open fracture or a vascular compromise or a compartment syndrome, and that can actually have to take the patient in as an emergency. Otherwise, basically, timing of the surgery is extremely important. If the injury is closed, it's better to wait for the edema to go down 1 week, 2 weeks, let the swelling go down, and then go ahead and approach the fracture. Now, the approach of the level in the sequence of fixation, you have to be very important. It is initially you have to stabilize the medial column. That is the first metatarsal joint and the second. Now, whether you want to do the second first or the first is just a matter of choice, really doesn't matter. But reduce it accurately, do a provisional fixation with a K-wire. And once you're absolutely satisfied that you've done a good anatomic alignment, only then go ahead and fix it. This is how this is a picture, a clinical picture. You can see the classical gap here. And once you put a towel clip, you can reduce it. And you have to aim for, and in order to see the good reduction, you have to remove the dorsal capsule. Otherwise, you can't know whether you have really reduced it well or not. The another way of screw fixation is that if you're putting a screw across the first TMT, it is important that you create a pilot hole, otherwise you can snap the cortex as you tighten the screw. Now, there are two ways you can screw the second metatarsal to the medial cuneiform. Either you can aim the screw from the second metatarsal into the cuneiform or from the cuneiform into the second metatarsal. It has been found that, it is easier to go from the second metatarsal into the cuneiform because cuneiform is a bigger bone. It's easier to aim it and gives enough stability. And anyway, you have opened it here anyway. So it's better to put, this is Dr. Vinod Panchababi's way of driving the screw. And this is the key screw because it is in the direction of the Lisfranc ligament. This is your very, very important screw. So once you fix this in, everything else falls into place. So which implant? Either you can use cortical screws, 3.5 or 4 mm. You could use dorsal plates. You can use tight rope, internal brace, and K-wires only for the lateral column. Never do a fixation or using a K-wires for the medial and the intermediate column. If there is an intercuneiform instability, which you have to check off intraoperatively, then you have to, again, stabilize that area. And this is one of the ways that you have to do. And if you see the fourth and the fifth column, you never put in the screw because you have to leave them mobile because that is the part of the foot which requires mobility, whereas the medial and the intermediate columns requires stability. So this is something that you have to look at. You can either fix or fuse. It is basically a choice depending on the type of injury, whether it's a purely ligamentous or a chronic injury. These are some of the dorsal plates that can be used, and we have found that the low profile plates which are come now are excellent ways of stabilizing the joints. And cadaveric studies have also shown that the metal plates on cyclic loading are much better. These are some of the fancy plates that are available now and also available in India. They're locking plates. So it doesn't matter how you fix it, whether you use a plate or a screw. Once you fix it well and you're confirmed that the outcome of these injuries are decided by an anatomical alignment and not by what you use, whether you use a plate or a screw. It is how you reduce it and then you stabilize it. Splinting for 10 to 14 days, non-weight bearing, short leg cast, non-weight bearing for 4 to 6 weeks, and then additional 4 to 6 weeks with another walking cast, and use an arch carbon support for 3 to 6 months, because these injuries are ligamentous injuries. They heal very slowly. You need to protect them. Hardware removal, lateral column stabilization can be removed at 6 to 12 weeks. You can remove the K-wires. Medial fixation should not be removed for 4 to 6 months. And some advocate that you can just leave it if it is not symptomatic. Outcomes, good to excellent. Internal fixation, 50 to 95% if patients with anatomic alignment. So here again, the key is you have to reduce these fractures the best possible way. And the poor results are only seen in non-anatomic alignment and the number of columns fixed. So you have to stabilize the medial and the intermediate column for sure. The third is optional, but the fourth and fifth, never try to stabilize it. Just put 2 K wires and that's it. Thank you very much.
Yes, sir. Gandhi, sir.
महेंद्र जी, आपने तो इतना कवर कर दिया कि हमको पूछने के लिए सवाल ही नहीं रखा है यार. Now, one thing here which we face quite commonly, like if he goes to a surgeon, I'm telling you a very practical scenario. He comes to me, I diagnose Lisfranc, or I don't diagnose either of the two things. Then he doesn't get all right. Then he goes to another surgeon. Even if it is diagnosed, even if he has been offered a surgical treatment, he has not done. So either not diagnosed or misdiagnosed, he comes late to you. The management protocols, does it remain the similar or does it alter?
Yeah, so when you open up, if you find that you have done an excellent reduction, and if your bone quality is good, the only cases where I would not use a screw is when there is a comminution, because you have nothing to stabilize it. Then I will use a dorsal plate, and the only thing against the plates were that they were not neuro profile. Now the new plates are so good profiles that you can just span them and just not worry about it. But you have to spend a lot of time debriding the joint and getting an anatomical reduction. The key in Lisfranc joint is not just putting it where you feel is right. It has to be perfect. So, spend some time. The way I go about it is I open it out, clean the joint well, remove all the debris. But sometimes a small piece of cartilage can prevent you from reducing it. And check for intercuneiform instability also, because if you miss that, you've just missed the bus. So check for everything, because the forces can dissipate in any direction. You wouldn't know. So once you've opened it, take that opportunity to look at every other instability. You fix the first TMT and do a provisional fixation with the K-wire of first, second, third. Look at the picture. Once you're convinced, then either use a plate or a screw, doesn't matter. Whether you should fuse it, if the patient is an athlete, very chronic, only purely ligamentous injury, I would be going towards more of fusion. But again, once you start fusing it, then you have to protect it for a longer time and so on. But outcomes at 6 months, 9 months, and 1 year, whether you fix it or fuse it, there is no issues.
Now, one thing which has always been an issue is constriction of the intertarsal ligament. What happens is when you are putting in a screw or lag screw types, then there is a collapse.
Very good question. All these screws are never to be put in a lag mode. They are positional screws. So this is a very, very important point. Excellent point,
Yes.
Rajesh. I think, this is the key. If you tighten it and if you put it in a compression mode, you're going to displace the reduction that you have achieved. So if they are positional screws, you have to reduce it, maintain with the K-wire, just put in the screw there, and that's it, you're done. So if you
In fact, that is where, if while debridement, if some amount of a cartilage has been debrided,
yes,
then you put in a small bone graft so that it allows the healing to take place, and you are not putting it in a compression mode, and you are maintaining the distance and not collapsing the distance.
Yes.
That is, the columns doesn't get collapsed.
Yes.
The transverse arch does not get collapsed.
Absolutely.
That is what is also equally important.
Absolutely. Absolutely.
Thank you for a wonderful presentation.
Thank you. Thank you, Rajesh.
You didn't leave any chance for us to ask the questions, boss.
Salim was worried I would overshoot in time. I hope I have not done that.
Oh, you're not. You're not. Interesting topics, it never overshoots, boss.
Thank you. Thank you.
I
think we have a good discussion.
Absolutely. So one question is from the audience. Regarding the mobilization part, when you have fixed it and fused, you have fused the the injury, how early would you ask them to weight bear? You would wait for.
So yeah, I mean, if you're planning at looking at fusion, then you're basically looking at 12 weeks.
12 weeks. Okay.
Yes, and then gradually put them in a rigid carbon fiber insole.
Right.
And gradually start wearing, because you have to protect the arch, because the amount of forces that go through these joints are pretty high.
Absolutely.
Yes.
Perfect. Yeah, Dr. Anil Kumar sir, any comments from your end?
Nothing, sir.
All good. Yeah.
I am doing this. Later, I will present all these things. Yeah.
Sure.
Yeah.
I must thank Zydus team. A super presentation on trauma and arthroplasty.
Right.
All presentations were very informative, generated a good discussion, and put everybody's good insight.
Right.
I thank you for a very educative program.
Before I close, can I just say one thing? Next year in August, I am organizing the 34th Indian Foot and Ankle Society Conference in Goa. So all of you are welcome. It is in the last week of August. So another reason for you to come to Goa. And
Mahendra, tu बोला हम उधर आके रहने को आते हैं यार.
Rajesh, you can come anytime. You don't need a conference to come to my place.
Yes, boss. Yes, I do.
Thank you, sir.
We'll catch up next month. We are going to be there before the IOCON. I'll catch up with you.
Yes.
Thank you.
Right.
And thank you to all the other faculties and the moderators. Thank you very much.
Thank you very much.
On behalf of Zydus and OrthoAcademicia, I would like to thank all our faculties and all the delegates who have joined. We have crossed today over 2,000 registrations today.
Wow.
And,
Super.
And with Ortho TV's help, and obviously we'll be seeing this number more increasing, because this program will be on Ortho TV for another year as well. So this continues.
I will take a small opportunity. I'm being little selfish on this, you know.
Yes,
IOCON is coming up, IOCON 2021.
Right.
So I invite all the delegates and all the faculty for the IOCON 2021, which is going to be held in Mahendra Bhai's heart, Goa. And it's a wonderful place. We are meeting after 2 years.
Yes.
And we have, fortunately and luckily, we have already crossed 2,650 registrations.
Wow.
And we hope to touch 5,000 very shortly. So we would invite all the people, all the delegates to please come join and take participation in meeting and camaraderie and teaching, everything.
Right.
Learning, teaching, everything.
Looking forward.
Looking forward, sir.
I'm sorry, I use this platform for inviting everybody.
Oh, sir, you're most welcome.
I told you I'm a little selfish on this, you know, because it's the motive was education plus fun, both.
Absolutely. So on behalf of Zydus, I thank all our faculties, and hopefully we'll meet soon at IOCON specially, and we would be everybody would be there to join them. Thank you, sir.
Thank you very much. Thank you, everybody.
Thank you.
Cheers.
Bye.
Bye.